about 80% of the course, just this little bit, and skin is the epidermis, for us is the mucosa. We talked about inflammatory changes, we talked about infections, we talked about tumors, and I just want to show you the normal architecture, if you will. And as we know that the basement membrane is what separates the mucosa from the submucosa. So any questions? This is normal architecture. Here's another example of normal architecture. I think the next slide is of a cancer, which shows abnormal architecture. So you don't have to be a rocket scientist to say that sure as hell doesn't look like this. And not only that, but these cells have all the features of malignancy. They're darker, hyperchromatic, they have different shapes, pleomorphic, and all those other things we talked about. And we know that when the baby is forming, part of the phases is this stage, and these are the branchial arches. You may recall you have like 5 of them, 1, 2, 3, 4, 5. And this is going to form the maxilla, the mandible, this is going to form the ear, all sorts of things. And we said that normally when these arches touch each other, they dissolve. But if some of these cells don't dissolve and last around later in life, they will form a cyst. This epithelium can start to just grow, called cystic degeneration. And that is a branchial arch cyst. Typically occurs in the neck along the sternomastoid muscle. Anywhere from the angle of the mandible down, you get the branchial arch cyst. And since there are lymph nodes in the neck, these are often lymphoepithelial cysts, which you'll see your text will refer to. Any questions, stop me as we go along. I'm going fairly quickly. We talked about a tumor called the teratoma. This occurs in the ovary. And what's unique about it, since we know that a sperm or an egg can by itself make a whole new baby, or certainly together they can make all the cells of a new baby, sometimes in an ovary tumor you form these tissues. And you see bone, cartilage, teeth, things like that. The reason I mention this to you, teratomas also form in the head and neck. Don't ask me how or why, but teratomas can form in the head and neck. We talked about dental development, did it around 6 months after fertilization. The basal cells start to invaginate down into the mesenchymal, the underlying connective tissue. So the bud stage, cap stage, bell stage. At this point, the tissue in here, can you see my arrow, folks? That's going to be the dental mesenchyme, or mesenchymal tissue. That's going to form everything but the enamel. The enamel is ectodermal, but everything inside here, the pulp, cementum, and dentum, is mesodermal, and the bone forms in response to the tooth. And here's an example of a tooth forming. This is the enamel organ. This is the dental mesenchyme. This is also tissues called the stellate reticulum. What you see here, 2 things I bring your attention to are, one, this is going to be the permanent tooth. The permanent tooth generally forms by coming off the primary tooth bud. So if you don't make a primary tooth, you may not make a permanent tooth. Also, this tissue in the stellate reticulum is very much like an ameloblastoma, the very aggressive dental tumor. So I just share that with you. And all of this we have. We'll just keep going. Now we get into some soft tissue developmental related problems once I take a quick bite. Melanotic macule, or focal melanosis. Same thing here, focal melanosis. It can be normal pigment, like a freckle. It can be in response to women taking birth control. Smokers, melanosis. There's physiologic pigmentation. Or there's one condition we talked about briefly, Peutz-Jeghers syndrome. forget perioral pigmentation in association with intestinal polyps, and that's important because the patient could get cancer from the polyps, intestinal cancer. This is macrocylia, or so-called double lip. It's just a variation of normal. Prominent rugae, just variation of normal. Here are enlarged gingiva. Now, in this course, we said it could be hereditary gingival fibromatosis. And as you might expect, there may be pseudopockets in here, things like that. We learned it could be due to chemical trauma, the calcium channel blocker like nifedipine, cyclosporine, and also Dilantin. We've learned in the epulous connective tissue chapter, this could theoretically be, if it's especially in just one area, a peripheral fibroma, peripheral ossifying fibroma. What do? We can take it out and biopsy it if we have a question. And whenever anything is in the gingiva peripherally, we take a periapical to make sure it's not coming from the bone and growing out. And the last thing is tomorrow we'll talk about this could be possibly leukemia, causing the leukemic infiltrate in the gingiva. Same thing here. Is this a pyogenic granuloma, an inflammatory condition? Maybe. Is this patient with some hormonal imbalance with this pubertal gingivitis, pregnancy gingivitis? Possibly. A pyogenic granuloma, peripheral ossifying fibroma, any of these things, we take a periapical and see if we see flexicalcification. Congenital lip pit, good thing to show you on your national board. It's also called commissure because it's by the commissure of the lip. Renee, I'm not looking at you. I hope you're not insulted. I'm looking at my screen. Okay. Cleft lip and cleft palate. And a bifid uvula is the simplest manifestation of a cleft. And you can almost see what's called a submucous cleft, how thin the tissue is back here. A bifid tongue, which again, developmental. We know the tongue forms from the lateral edges and meets in the midline, and here it just didn't meet anterior. Hyperplastic Freeman, generally labial or lingual. This is labial and lingual, also called ankyloglossia or tongue tie. I'm going to stop and say, any questions? Good. Hopefully this is just, again, this is meant to be a good review. So if you see it in a couple of days or whenever, you'll say, yeah, that makes sense. These, whoopsie daisy. These are the circumvallate papillae. This is fairly normal. And with the circumvallate papillae are like a V, they meet at the foramen cecum. And the foramen cecum is where the thyroid gland starts to develop. It drops down into the neck. The thyroid gland forms down in the neck. It's like a butterfly bilobe gland. Follows the thyroglossal duct tract, and sometimes you can get a system on that track. Sublingual varices. I'm only going to show you the important things now. A lot of the interesting things will just can. But sublingual varices. This is a fissure tongue. In fact, we're going to see this slide tomorrow. Yes, it's a fissure tongue, which is developmental. But we see angular chylitis, called Perlesh, which is a fungal infection. And if I were to say, Carolyn, what about the papillae on the tongue? What would you tell me? Dana can help you. What about the papillae? Are they prominent? Oh, this is a final exam slide too. Actually, you should say, I don't see any papillae on the tongue. There are none, because this is what you see. We talked a little bit today about magenta tongue, red tongue, deep papillation. This is classic with a major anemia. You get loss of papillae on the tongue, and you get angular chylitis. So this what? Bald. Well, let me rephrase that. Forgive me, Dana gets an A+ and my apology. There may be a few fungiform, but there are no filiform papillae. So there are really no filiform papillae to speak of here. Have all these little nodules. So I'm sorry, Dean, I was a bad boy. I apologize. Here, again, it's red. We don't know if that's anything but a fissured tongue. Fissured tongue. Now we see the opposite of lack of filiform papillae. We see an increased number. This is white hairy tongue. Excuse me, please.
Okay.
Go ahead,
Get up,
Mark,
so.
speaking.
Kind of
Yes, please.
whatever's left.